goes without saying, very appreciative of Dr. Tamara Pringsheim presenting the webinar today. She is a professor at the University of Calgary, Department of Clinical Neurosciences, Psychiatry, Pediatrics, and Community Health Sciences, Program Lead of Tourette and Pediatric Movement Disorders, Deputy Director of Clinical Research at the Matheson Center for Mental Health Research and Education, President of the Tourette OCD Alberta Network, and is an evidence-based medicine methodologist of the American Academy of Neurology. Thank you, Dr. Pringsheim.
Thanks, Julian, and thanks to everyone who's taking part in the webinar this morning. We had a request to speak specifically about substance use disorders in people with Tourette syndrome and OCD, and I think this is a relevant and important topic. So my objectives this morning are to review data something keeps popping up on my screen, to review data on comorbidity between substance use disorders and Tourette syndrome and obsessive-compulsive disorder, to discuss potential causal mechanisms for this comorbidity, and to discuss the implications for screening for substance use disorders in people with Tourette syndrome and or OCD. So, by all means, I am not a substance use disorder expert, but I thought it would be relevant just to go over what substance use disorders are. And these are defined by the presence of 11 specific diagnostic criteria, which are outlined in the DSM-5. And this includes hazardous use of a substance, experiencing social or interpersonal problems related to use of the substance, neglecting major roles to use the substance, experiencing withdrawal symptoms, experiencing tolerance to the substance, using larger amounts of the substance or using the substance for longer amounts of time, having repeated attempts to control use of the substance or to quit using the substance, spending much time using the substance, developing physical or psychological problems related to use of the substance, giving up activities to use the substance, and experiencing cravings. So for the diagnostic criteria, the diagnosis requires 2 or more criteria within a 12-month period. And to be defined as mild, one has to have meet 2 to 3 criteria. To be defined as moderate, one needs to experience 4 or 5 criteria. And to be defined as severe, one must experience 6 or more criteria. So the type of substance use disorder is classified by the type of substance used. So the most common types of substance use disorders seen in clinical practice include alcohol use disorder, tobacco use disorder, cannabis use disorder, stimulant use disorder, hallucinogen use disorder, and opioid use disorder. So just briefly, on the treatment of substance use disorders, the most effective way to help someone with a substance use problem who may be at risk for developing a substance use disorder is to intervene early before the condition can progress. And so the use of screening in general medical or mental health setting can help identify those at risk. Less severe forms of substance use can respond to brief interventions. So this could be brief counseling, for example. And there are evidence-based behavioral therapies that, if implemented with good fidelity, can be effective in treating substance use disorders. There are medications as well that are effective in treating serious substance use disorders, including alcohol and opiate use disorders. And it's been shown that inpatient, outpatient, and residential treatment are cost effective compared to no treatment. So what is the best way we can determine whether or not there's an association between Tourette syndrome and a substance use disorder? So obviously we can't do experimental studies, that would be unethical, but we can make use of population-based studies. So this is a type of study that includes all people within a defined geographic area who have been diagnosed with these disorders. And that's typically done either through a health registry or a population-based health survey. This type of study will have a large sample size and allow more complex analyses and comparisons with non-affected controls from the same population. And this is less biased than clinical samples. So I could certainly do a survey of all the people I see in my clinic with Tourette syndrome and find out how many of them have substance use. But that would be, of course, biased, because perhaps my clinic attracts a certain population of people, and people who don't know about my clinic, or don't live in Calgary or don't live in Alberta, would be excluded from that sample. And that's why we like to, when we look at for associations of this type, we like to use these large population-based samples. So let's start by talking about Tourette syndrome and substance use disorders. Due to the nature of our webinars, I'm going to assume that all of you have a basic understanding of what Tourette syndrome is. You know that this is a childhood onset chronic tic disorder that is fairly common. Now, the area of comorbidity between Tourette syndrome and substance use disorders has really been understudied. So there's, looking at the data that is available, there is one cross-sectional study of psychiatric comorbidity in people with Tourette syndrome. It's a large sample of 1,000 people with Tourette syndrome who are seen within specialist clinics, which found that 6% had a lifetime history of substance use disorder. When they divided this between adolescents and adults, it was 3% of adolescents and 19% of adults. And they did not find any differences in the rate of substance use disorders between men and women. I think that the best study that we have on this topic comes from a study that was performed in Sweden. And this is the first and only prospective population-based study of the association between Tourette syndrome and substance use disorder. And it was published in 2020 in the journal Biological Psychiatry. The first author is Virtanen, so I'm going to be referring to this as the Virtanen study. And its title is The Association of Tourette Syndrome and Chronic Tic Disorder with Subsequent Risk of Alcohol or Drug-Related Disorders, Criminal Convictions, and Death. I'm going to focus on the alcohol and drug-related disorder outcomes. So this study was performed using the Swedish population-based registers, and the goals of the study were to estimate the risk of alcohol and drug-related disorders in people with Tourette syndrome, to establish the extent to which the association is explained by comorbid psychiatric disorders, and to investigate whether the association is influenced by familial factors shared by siblings. So they included all individuals living in Sweden between January 1st, 1973 and December 31st, 2013. And these people were identified through the Swedish Total Population Register. And they're able to link multiple databases, including the National Patient Register. And this cohort of people was followed through their various registers from 1973 or their 10th birthday, whichever came later, until the end of 2013. And they identified people with a lifetime diagnosis of Tourette syndrome registered in this 40-year period and in the National Patient Register using ICD codes. The ICD codes in the Swedish National Patient Register have excellent validity and reliability, and the authors have formally studied this topic. So they've made sure that when someone is coded using one of these ICD codes for Tourette syndrome, that they do in fact have Tourette syndrome. So they define their substance misuse outcomes as any ICD codes for the diagnoses of mental and behavioral disorder due to psychoactive substance use, alcohol or drug-related somatic conditions, poisoning by drugs or alcohol. And these codes had to occur between, again, 1973 and 2013. And to investigate if psychiatric comorbidities contributed to substance misuse outcomes, they included lifetime diagnoses of ADHD, conduct disorder, pervasive developmental disorders, OCD, anxiety disorders, depressive disorders, psychotic, and bipolar disorders. And for their statistical analyses, they looked at the association between Tourette syndrome and substance use using a Cox proportional hazard regression with all models adjusted for both sex and birth year. For AIM-2, they repeated their main analysis, excluding different groups of comorbid psychiatric disorders one at a time. And for AIM-3, they looked at the association between Tourette syndrome and substance use in a subsample of full siblings within the cohort who were discordant for the diagnosis of Tourette syndrome. So one person in the sibling pair had to have Tourette syndrome, and the other person in the pair could not have been diagnosed with Tourette syndrome. So this study included over 14 million people with a median length of follow-up of 26 years. And in that cohort of 14 million, 7,832 were diagnosed with Tourette syndrome between 1973 and 2013. And 76% of these people were men. This is certainly what we would expect, as easily we see at least 3 men for every woman who has Tourette syndrome. 15.9% of the people with Tourette syndrome had any substance misuse outcome, compared to 6.8% of the unaffected general population who did not have Tourette syndrome. And if we look specifically at alcohol-related disorder, 8.4% of people with Tourette syndrome had an alcohol-related disorder, compared to 3.8% of the general population, and 8% had any drug-related disorder, compared to 1.3% of the general population. Now, this is their sort of overall summary of what they found. And so you can see across the top, this is the outcome. The first column is the outcome, the substance misuse outcome. The second column is the rate in patients that have Tourette syndrome or chronic tic disorder. The third column is the rate in the general population who does not have Tourette syndrome or a tic disorder. And the fourth column is the hazard ratio. So there was a greater risk of substance misuse outcomes in people with Tourette syndrome than the general population. And this is true for all substance misuse outcomes: alcohol-related disorder, drug-related disorder, disorder due to cannabis, opioids, sedatives, stimulants, or other substances, as well as substance-related convictions and substance-related deaths. And if we compare men to women, men had a higher risk of an alcohol-related disorder, whereas women had a higher risk of a drug-related disorder. And this is, so if we look here in the column, I'm not sure if you can see my arrow, but for alcohol-related disorder in men, 8.3% of people with Tourette's had alcohol-related disorder, compared to 4.6% of men in the unaffected general population. And that gives you a hazard ratio of 4.53. And then the corresponding risk in women was 2.94. So it's higher in men than women. And the 95% confidence intervals don't overlap. So that means it's significantly higher in men compared to women. If we look at the drug-related disorders, the numbers are fairly similar. men versus women for all the different outcomes. But for women, there was a higher risk of drug-related disorder, and that's mainly because in women, with respect to cannabis use, women in the control population who do not have Tourette syndrome, their cannabis use was quite low in comparison to women who had Tourette syndrome. So that really escalates the hazard ratio for a cannabis use disorder, being 9.31 compared to males, which was 4.77. And again, because the odds ratios don't overlap, women had a significantly higher risk of cannabis related disorder than men. So looking at the role of psychiatric comorbidities, as expected, there was extensive psychiatric comorbidities in our Tourette syndrome cohort, with 72% having a record of at least one psychiatric disorder in their lifetime. The most common disorders found were attention deficit hyperactivity disorders, pervasive developmental disorders, and anxiety disorders. And excluding individuals with ADHD and anxiety disorders significantly decreased, but did not eliminate the risk of substance misuse outcomes in individuals with Tourette syndrome. The elevated risk for substance misuse outcomes persisted even when all psychiatric comorbidities were excluded at the same time. So certainly, yes, there is less of a risk if you don't have a comorbid psychiatric disorder, but the risk is still elevated in people with isolated tic disorders in the absence of comorbidity. So then let's look at the within family analysis. So in this specific analysis, this cohort included almost 3 million families where there were at least 2 full siblings, of whom 5,310 were discordant for Tourette syndrome. So one sibling has Tourette, the other sibling does not. And when we looked at the substance misuse outcomes in this sibling cohort, there was an attenuation of the magnitude of the association between Tourette syndrome and substance misuse outcomes compared to the main analysis. The risks were still significantly higher in individuals with Tourette syndrome compared to their unaffected siblings, but it was definitely a lower risk compared to the non-sibling comparison. So what are the strengths and limitations of this study? I'd say that the major strength is that this is a large population-based sample that has a very long follow-up period. So you saw that the length of follow-up, like through the cohorts, was 26 years. So you really, it's not just a single snapshot in time. You know, we're looking at people who are, could be diagnosed with Tourette syndrome at age 9 and following them until they're 40. So I think that's quite impressive to have such a long follow-up period. And we know that these diagnostic codes for Tourette syndrome are very reliable. There are a few data resources where there is the ability to do this type of work. And this, I think the Scandinavian population-based registered are very unique in this regard. And I think the ability to look at siblings is really important as it accounts for familial confounding. So we know that a number of the things that happen to us, they're not just because of our genes, but also because of the environment that we grew up in. So I think this is very important. So limitations include that the results may not generalize to people with mild tic disorders who did not seek health services. So in order to be detected as having Tourette syndrome, you have to have seen a health professional and be coded within the Swedish National Population-Based Register as having this disorder. So if you never seek medical help, then you would not be counted. So that, we know that people on the milder end of symptoms may not seek health care. It may not be picked up through, their family doctor or pediatrician. So people with mild tic disorders are likely not accounted for. Similarly, only substance misuse disorders severe enough to require health services are captured as well. So again, those mild cases will be missed. Surveillance bias, I think, is probably one of the main issues here. So people with Tourette syndrome are going to, people who have been diagnosed with Tourette syndrome are going to be followed more intensely, right? So they're going to have more encounters with health professionals, and there'll be more people there to make the diagnosis of substance use disorder, and that can be recorded as well. Whereas, somebody who never sees the doctor is potentially this is never going to come to light. So surveillance bias can definitely affect the results. And then finally, the validity of the substance use codes in the Swedish National Register have not been formally examined. So in terms of the conclusions of this study, Tourette syndrome is associated with substance use disorders independent of psychiatric comorbidity and familial factors shared between siblings. Screening for substance use disorders should be part of routine clinical practice, particularly in patients with comorbid ADHD, since we know that the risk is lower in people without this comorbid disorder. And very important to remember that the majority of people with Tourette syndrome do not have a substance use disorder. So as I showed you, about 16% of people with Tourette syndrome in their cohort had any substance misuse outcome. That means that 85% of people with Tourette syndrome do not have a substance use disorder. So it's important that we don't automatically assume that, oh, you have Tourette syndrome, you probably have a substance use disorder, because the majority of them will not. They're at higher risk compared to the general population, but the majority of them will not have a substance use disorder. So let's move on to obsessive-compulsive disorder and substance use disorder now. There's much more data on the association between OCD and substance use disorder. In fact, there was a recent systematic review published in the past year, and they did a meta-analysis of 8 studies, which assessed for comorbid substance use in people with OCD, with a total of 2,406 participants. And they found that compared to people without OCD, the relative risk was 10 for having a substance use disorder. The 95% confidence intervals are a bit wide for this estimate. You see they go from 5 to 18, but there is a significant, in any case, higher risk of substance use disorders in people with OCD. I thought that we would take a deeper dive into a study that I actually performed a number of years ago with Paul Arnold and one of my students. And I thought we would look at this study because it has Canadian data. So this was a study looking at the prevalence of diagnosed OCD and associated comorbidities using a population-based sample in Canada. And the objectives of that study were to determine the prevalence of diagnosed OCD and associated comorbidities using population-based data from the Canadian Community Health Survey, Mental Health, and to examine socio-demographic factors and health service utilization. Obviously, for the purposes of this talk, I'm going to focus on the substance use outcomes. So in terms of our methodology, we used a Statistics Canada cross-sectional survey, which was designed to collect information on health status, health utilization, and health determinants for the Canadian population over the age of 15. And this study included 25,000 participants who were randomly selected from households across Canada with a response rate of approximately 80%. And 87% of the interviews were performed in person by field interviewers in the participants' household. In terms of the OCD diagnosis, survey participants were asked if they had ever been diagnosed by a healthcare professional with OCD. People who said yes to this question were included in the OCD population. In terms of the substance use definitions, we looked at alcohol use and dependence, substance use and dependence, both lifetime and in the past 12 months, and whether or not people were coded as having alcohol use or dependence, substance use or dependence, was based on specific questions that were asked through the interviews regarding the use of these substances. For dependence, there had to be at least 3 symptoms of tolerance, withdrawal, increased consumption, attempts to quit, time lost, reduced activities, and continued use. And for abuse, one had to have at least 1 of 4 symptoms of recurrent use leading to failure to complete obligations, use in situations that are physically hazardous, related legal problems, continued use regardless of social and interpersonal problems caused or worsened by use. In terms of the prevalence of OCD that we found in our general sample, it was about 1%. And this is in line with other population-based estimates, which generally find figures between 1 and 3% for OCD. If we look at the alcohol dependence, so this is lifetime alcohol dependence criteria met. In the OCD population, it was 12% compared to about 3% in the general population. So you can see that's an odds ratio of nearly 4. So there's an increased risk of having a lifetime, meeting the lifetime diagnostic criteria for alcohol dependence. If we look at alcohol dependence in the past 12 months, the prevalence in people with OCD was 7.6% compared to nearly 1% in the general population, again, with an odds ratio which is elevated at 6.83. For substance abuse or dependence lifetime criteria, it was 36% in the OCD group compared to 8.3% in the general population, again, with an elevation in the odds ratio. And if we look at substance use or dependence in the past 12 months, it was 10.6% versus 1.7% in the general population, again, with a significantly elevated odds ratio. So again, if we look at strengths and limitations of this study, this was a population-based study, which included Canadians from across the country. In terms of limitations, we relied on self-report of diagnosed OCD. And so again, we're going to omit people who are never diagnosed or who do not seek professional help. These results may not apply to people with mild OCD symptoms. And unlike the Swedish study, we were unable to do an adjustment for comorbid disorders. All of our estimates were adjusted based on age and sex, but we couldn't do the adjustment for comorbid disorders. There just weren't enough people with OCD in our sample. So what are the potential causal mechanisms for the comorbidity between Tourette syndrome, OCD, and substance use? So first thing we need to think about is genetic liability or shared environmental risk factors. And the Vertanen study really tried to get at this through their dedicated sibling analysis. So in their sibling comparison analysis, they found that the risk of substance use decreased by 50% if you compared siblings. So this suggests that both genetic and shared environmental risk factors are present for substance use in people with Tourette syndrome. I was not able to find a specific sibling comparison in OCD, but we know that obsessive-compulsive disorder like Tourette syndrome is a highly heritable condition. So while I can't say with certainty that this is the case in OCD, I would not be surprised if we found a decrease in the risk of substance use if we looked at non-affected siblings of patients who have OCD. The other hypothesis is that this could be a self-medication. So people with Tourette syndrome and OCD may use alcohol or drugs to cope with their symptoms. And certainly we have randomized controlled trial data that shows that cannabis can decrease tics. So the use of these substances may be an effort for people to try to cope with their symptoms. So what are the implications? So based on review of this data, 16% of people with Tourette syndrome and 30% of people with OCD experience substance use disorders. While this is higher than the general population, the majority of people with Tourette syndrome and OCD do not have substance use disorders. And as I mentioned right at the beginning of the talk, early identification is associated with better outcomes. So it's important for us to try to identify and treat substance use early. So how do we do that? Well, there are a number of evidence-based screening tools for substance use. This is something from the US government, and it's a list of different screening tools that can be used in adolescents and in adults, and the different types of substances that they screen for. So there are many different screeners that can be applied in your practice to screen patients for substance use disorders. I use in my practice, I use something called the TAPS tool, and it was adapted through two of the instruments that were recommended on the previous screen, the ASSIST and the NITA screening tools, and it was specifically developed for use in primary care. So there's two instruments, there's the TAPS 1 and the TAPS 2. And the TAPS 1 is a 4-item screening for tobacco, alcohol, prescription medications, and illicit substance use in the past year. So it's just simple questions about this. And then in the TAPS 2, it's a 9-item brief assessment of tobacco, alcohol, prescription medication, and illicit substance use in the past 3 months. And they found that this instrument has good sensitivity and specificity for the identification of substance use disorders compared to a reference standard, which was the modified composite international diagnostic interview. So in my clinic, I give people the TAPS 1 and TAPS 2 to fill out before they meet me for the first time. And then so they fill it out themselves. And then when they are in the exam room with me and I'm going through their history, I'll go over the answers with them together and clarify anything that looks like it could be concerning use. So in summary, people with Tourette syndrome and OCD are at higher risk of substance use disorders than the general population, and we should consider screening all patients as a part of our routine practice. And early identification and treatment has the ability to improve outcomes. That's all I have to say this morning.